Good morning, all. We're going to begin our session on, for us surgeons, it's important to understand what non-surgeons want from us regarding diabetes targets. So this session will focus on how do we optimize the outcomes in diabetes treatment. We're going to have two moderators with us, Dr. Samantha Hawking, she's from Sydney, here in Australia, and Phil Shower from Louisiana, on the Pennington Biomedical Science Center or something similar, right? Yeah, it's too long, yeah. And the first speaker who will replace Dr. Jamie Yard is Thaisa Petri. She's from Brazil. She's an endocrinologist from the Center of Diabetes and Obesity, Oswaldo Cruz German Hospital. And today is her birthday. So, happy birthday.
Thank you very much. Good morning, everybody. So I will start this session talking about diabetes treatments in 2024 and its endpoints. I want to thank Ildiko and Ricardo Cohen for the invitation. I will try to replace Jamie. I don't have any disclosure for this presentation. We all know that diabetes prevalence is increasing a lot and very fast in the last years, and there is a prediction that from here to 2045, it will increase almost 50%. And the diabetes complications are brutal. We know that the retinopathy is still the most important cause of blindness. Nephropathy increased worldwide by about 74% between 1990 and 2017. And neuropathy, which prevalence variates to 10 to 70% depending on the country. So mortality has decreased among patients with type 2 diabetes over time, but there is still a gap comparing to matched controls that needs to be reduced. And mortality increases little in the population with uncomplicated diabetes compared to the general population, but when patients develop nephropathy, the mortality increases a lot. Previously, the only target that we had in the guidelines was glycemic control. This is because studies as UKPDS, I studied design in 1977 with patients with type 2 diabetes newly diagnosed, allocated to an intensive arm using sulfonylureas, insulin or metformin, medications with no other effects than reduce glycemia. And until now, this intensive arm shows a legacy effect. So 24 years after trial end, we still see the intensive arm reducing microvascular, macrovascular disease, and death. But since then, a lot of new medications appeared, and a lot of studies show that these medications, as SGLT2 inhibitors and GLP-1 agonists, have other effects than only glycemic control. So they are medications that reduce nephropathy and cardiovascular disease. And more than that, select trials showed 20% of reduction in cardiovascular events with semaglutide. So it's the first time that an obesity medication shows a reduction in cardiovascular events in patients with no diabetes. And then we see here in Association of American Association of Endocrinologists, they put in this table, you see in blue benefits in some medications, more modern medications showing benefits in nephropathy, cardiovascular disease, weight loss, that it's an important target now, the most important target now, and MASH. And because of that, currently, the guidelines recommended reduction of cardiorenal endpoints and not only glycemic control, that are pathologies related to mortality and complications in this population. So we see here that we need to build pillars in order to reduce these diabetes complications. So its patients have to have a glycemic control, lipid and blood pressure control, and everything. Furthermore, we have evidence that weight loss is essential to improve these outcomes. And we see that in weight loss as small as 5%, the health starts to improve, and with more weight loss, we will have more health improvement. And we know that more than 15% of weight loss causes a disruption of disease continuum, changing all the prognosis of diabetes. We are among surgeons here, and we all know this is Mingroni and Francesco randomized control trial after 10 years of follow-up. And we know that in the first 2 years, this patient shows a huge weight loss with diabetes remission, and then over time, this remission rate of diabetes reduces. This is because the attenuation of effects of surgery and maybe the progression of the disease. And we have to have in mind that our patients will show different trajectories of weight loss. And if a patient is in that first and second trajectories, they will not lose weight appropriately. It will not be enough to improve health. And when we see this Scandinavian registry with more than 65,000 patients, we see that patients with diabetes who achieved remission in the first year post-op had lower mortality than those who did not. So why not introduce pharmacotherapy here in order to maybe decrease the mortality of these patients that didn't remit? And then nowadays the guidelines are changing their targets, and this is ADA guideline of 2024, and then firstly separate patients who need cardiorenal risk reduction from that patients who need glycemic control and weight management. So accordingly to each risk, you will start an intervention, and if the patient doesn't have any cardiorenal risk, you can try to achieve go back and put the glycemic control in the first target. This is ACA, and you see here too that the first step is assess BMI of the patients. Because according to the BMI, we will choose the right intervention. And if the patient has high BMIs, you need to be more aggressive in the treatment. And the most important thing in this presentation is have in mind that each patient will need one intervention according to its risk factors, family histories, and preferences. This is important. It is important to hear the patient and know what is better for him. Accordingly to this, it's his risk factors. So I brought a case here just for as an example to understand how much the patient is unique. This is a male patient with BMI of 40, A1C 8%, and he has had chronic kidney disease and heart attack 2 years ago. And then after 2 years that he was submitted to metabolic surgery, he has a BMI of 27, A1C of 6.5%, and he still has chronic kidney disease, and he had a heart attack 4 years ago. So everybody's happy, the patient's happy, the surgeon is happy, the multidisciplinary team is happy. But should you keep this patient without medication? Or he deserves a medication, for example, as SGLT2 inhibitor in order to reduce the progression of chronic kidney disease or a heart failure. We have to think about it. Thank you.
Our next speaker is Francesco Rubino from the King's College London. He'll add the surgeon's perspective on how can we predict the outcomes. Is it procedure selection that ILDI showed that there's hardly a place for the sleeve in people with diabetes and obesity? And what do you think about the prediction of outcomes in your view?
So these are my disclosures. Good morning, everybody. Some of the things I'm about to say have been already beautifully demonstrated with some of the studies the previous speakers presented. But I would like to focus on some points that I think have importance for clinical practice, but also for our understanding of diabetes more in general. In 2002, I published this paper called Potential Surgery for Curing Type 2 Diabetes Mellitus. At the time, we still call it mellitus, and so that already tells you how old this paper is, probably. But in that paper, we said a number of controversial things. For one, that surgery should be considered for treatment of type 2 diabetes. Second, that procedures that bypass the bowel may be more effective for type 2 diabetes. It was controversial then, and it's probably, given the studies that have been presented now, seems to be more solid. But another thing was that there's a potential for curing diabetes that I thought was fundamentally important, so important to put it in the title. Of course, curing diabetes is almost blasphemous, and looked blasphemous to many at the time. And in fact, the reactions both in the medical field and outside wasn't necessarily very welcoming. Some people thought that these were, exaggerations of all sorts. But even myself, I wasn't, when I say potential, I meant potential. I didn't say that we were sure we could cure it, but there was a possibility, looking at the old historical data, that diabetes disappears. What does it mean? Is it going away for real? Is it true? So I thought it was something to look at, but certainly not something that you could take for sure. So when the anchor woman of this important show in the United States asked me if surgery can cure diabetes, she said, you have to answer either yes or no. You don't have a third thing. And I just tried to push back, and I said, I can't answer that thing. The ADA is going to disqualify me from any other meeting in the world. And then I said, well, if I can't answer the question with a yes or no, if you just want an answer, then I would say for the moment I would stay on the cautious side. I would say no. And so they didn't like the answer, and they took another surgeon for that particular segment so that they could have the answer they wanted. It was yes, indeed. Now, fast forward many years after, I think I would, if I'd be asked that question again, I would say yes. The answer is yes. Now, it doesn't mean that we can cure diabetes in 100% of people, but that doesn't mean that you cannot achieve a cure, even if you can do it in 20% or even 10%. And that 10%, I think it's more than 10%, but even 10% tells you something about diabetes. Because if it's curable, at least in some, there's some mechanism out there that this surgery is actually tackling, and that understanding it might help us understand better diabetes and potentially find better cures in the future. But certainly, a patient like this, it's hard to tell you don't have a cure of diabetes. I mean, if we look at 14 plus 15 years and 20 years, there are reports that 20 years of people who don't have any sign of diabetes. I mean, we have to scratch our head and say, should we really continue to tell this person, you're sick, you have diabetes, or that is not fair? And before even being not scientifically correct. Now, diabetes remission, as you saw, lasts long, not in everybody, there is relapse, but you can see 10 years after surgery in this randomized trial, 37% overall, the people who had one type of surgery, BPD or bypass, more with BPD, of course, had remission, lasting remission. Now, importantly about the weight loss issues, interpreting weight loss and diabetes recurrence is very difficult because they all go together. And so there is this assumption that the direction of causality is only one way. And we tend to interpret resolution of diabetes as an outcome of weight loss. If you just for a moment forget about it, it could be that it's not the case, that there is something else, maybe a change in metabolism that is inducing both type of outcomes at the same time. It's in the same way as if you treat pneumonia with an antibiotic, you're going to see symptoms of pneumonia both going away, and if you correlate the symptoms, there will be a correlation, of course. Now, if you assume causality between symptoms, you end up with a conclusion that might not be correct. In fact, in this study, we found that patients who had remission and patients who did not have remission had no difference in weight loss, and people who actually had relapse after remission had no difference in weight loss. Now, these findings conflict with other studies that show weight loss is proportional, remission is proportional to weight loss, but be a little bit more attentive to the fact that this study only focused on two procedures that are called gastric bypass and biliopancreatic diversion. The more you go on procedures that are diversionary in the intestine, very powerful, the least you start seeing the dependence on weight loss. And this is probably why in the study there was no correlation. So this also supports weight-independent mechanism. I think the mechanism by which diabetes is improved is obviously still unclear. We know a number of factors, intestinal physiology matters, but we don't know exactly what the reason is. But this focus on intestinal physiology does, I think, contribute to acceptance of diabetes surgery, because clinical observations that surgery could remove diabetes, induce complete resolution, date back to 1925 with publications in The Lancet. But nobody really thought about using surgery for diabetes. I would suggest until more recently we started to understand the biology of this gut and the biology of metabolic surgery. And I think that gives us confidence that surgery is indeed an appropriate treatment for diabetes, biologically and clinically, of course. Remission rates, very important with many studies that you saw before. Importantly, reduction of medication use is also another important, clinically valuable, important outcome of surgery. Inevitably, at the end of the day, the most important thing is if we increase survival, and every study shows that in bariatric surgery increases survival, but if you operate on people with type 2 diabetes at baseline, that reduction of mortality is twofold as important than in people without diabetes. And of course, cost effectiveness follows the same pattern, more cost effective in people with baseline diabetes. Every randomized trial that has compared surgery and medications got the same outcome. Surgery is superior with level 1 evidence to medications. Of course, we can always have newer medication and we have to update this evidence, but I think it's quite a robust evidence so far. And then obviously, because of that evidence, the surgery is recommended in patients with diabetes, even with BMI as low as 30 or 27.5. I think these are even more now probably conservative recommendations, and probably they are due for some adaptation in light of the newer evidence. Now, based on the whole evidence available, I think there is now agreement, nobody would disagree if we say that metabolic surgery is the most powerful anti-diabetes intervention that we know. And I think that's quite obvious. Now, despite this interest and despite this acknowledgement of the power of surgery, this is not what the public understands. We had a survey in United States last year that looked at patients with obesity, actually, and we asked what is the most effective treatment today for type 2 diabetes, and you can see that surgery is not really much in their minds as an option. People don't know. Maybe we haven't communicated well enough, or maybe there are some sort of other reasons why changing this knowledge, this idea of diet and exercise being the best treatment is very resilient and difficult to change. We also ask what is the best intervention for somebody like you, and you can see, surgery not being the most appealing to most people, so it remains, despite of the power of the intervention. Now, I would say, if you had an operation that could improve, induce remission of Crohn's disease or ulcerative colitis as much as you have for diabetes, if you have an operation that could cure many other diseases that we are treating, you would be surprised about these numbers, and you would be also thinking that we have a problem. And I think this is something that we need to consider. Why are we not able to communicate to people that there is a valuable treatment that can save lives, that can cure potentially their disease? Is there something that maybe the medical profession is responsible for? Are we divided maybe over our communications based on our personal professional interests as opposed to looking at the bigger picture and proposing to people what is best for them? I think we have to interrogate ourselves about this. When you see these numbers, we're not doing our job if we don't communicate evidence-based to people. That's my opinion. Most likely it's because also people think that surgery is very risky, and there's this misperception that bariatric surgery is extremely risky, it's dangerous, it's drastic, and this is actually contrast with reality, as we just showed yesterday in another session, that bariatric surgery is safer than probably all or most, at least most other type of general surgery operations, both in terms of perioperative outcomes and in terms of longer-term safety. You can see less remission rates after bariatric surgery compared to virtually any other form of general surgery that we do in modern hospitals. Now, choosing the procedure for type 2 diabetes, very briefly, there are a lot of studies that point towards bigger surgery, bigger results, BPD more effective than bypass in this particular study from Jill Trudeman-Groningen. I was also part of co-PI in that study, but also better, not only in terms of remission, better outcomes in terms of medication reduction with BPD compared to bypass. However, on the other hand, of course, BPD, as even in a small study like this, carries a risk of more metabolic complications, including clinically relevant ones, which you have to also always consider in the risk-benefit analysis. Here is the results of the STAMPEDE trial. Phil Shower is here in the room, comparing Roux-en-Y gastric bypass and sleeve gastrectomy. There was no specific difference in remission rate between sleeve and bypass in this randomized trial, but you can see that if you just delve a little bit deeper, people who had gastric bypass were using less medications than sleeve gastrectomy to achieve optimized glycemic control. So still, even here, you can see that there is more support for rerouting the bowel as opposed to sleeve gastrectomy if you want to achieve better glycemic control, reduction of medication usage, including diabetic and cardiovasculars in this case. So the study, I will go quick, has been already mentioned. It's not a randomized study, but it's a large study looking at patients with had sleeve or bypass, and again, slightly higher remission rates with bypass, but certainly much better control long-term with less relapse events. So substantially, surgery more effective than medical therapy. There's a gradient effect, BPD, although with more problems with safety issues than gastric bypass more than sleeve, and sleeve more than gastric band for those who already still do any gastric band. So, and the efficacy is above and below BMI 35. However, while these are, in theory, principles that we should use to choose the procedure, then of course clinical practice is a different story because we deal with patients who are different from one another. So you can't go by the book and say, why gastric bypass is better than sleeve, I'm going to do bypass in everybody, or BPD because this is what the trial says. So I want to give you just some examples that might seem extreme, but this is what we deal with in general in our practice. So for instance, this is a person who has type 2 diabetes, BMI 47, very poorly controlled type 2 diabetes, on insulin, A1C completely out of the roof. And the problem, however, this person has interstitial lung disease requiring lung transplant. Completely breathless and minimal effort, a patient that required oxygen continuously, possibly a contraindication to surgery in historical days. In fact, this patient had been given a prognosis of 6 to 12 months by his thoracic surgeon, and the thoracic surgeon said, I'm not going to operate on you for the transplant because of your obesity and your type 2 diabetes poorly controlled. So we had to make a hard decision, taking the risk for him and agreeing with the patient and with a multidisciplinary group of colleagues, and we operated. Of course, we didn't do a gastric bypass because in this case, the sooner you get out of the operating room, reasonably the better. So we did a sleeve gastrectomy, even though the diabetes was perhaps suggesting bypass. This patient was extubated at the end of the procedure. He went home in 4 days with diabetes optimization. And 2.5 years after surgery, this person has no diabetes, so he got remission of diabetes. And now he has improved his function so much that the transplant surgeon says, you don't meet criteria for transplant anymore. So quite an interesting case. Similar other very challenging cases. This is a patient with a liver transplant before, type 2 diabetes on insulin. I would have chosen gastric bypass, obviously, in a person like this in normal circumstances. But you can see here the bowel, there's a massive hernia, ventral hernia. The bowel comes out of the abdomen and even all the way up to almost the costal margin. So you have very limited room for doing a laparoscopy or putting trocar. So we had to operate with the trocars very up in the subcostal area. I think we couldn't do much more than a sleeve gastrectomy in that case, and we did it, and the patient did well, and has also improved his clinical situation. So in short is to say that obviously in principle there's gradient of efficacy with procedures, but surgery is also very much real life, and you have to go with what you have. Very briefly, I want to say that while surgery changes diabetes care, diabetes also changes the care, changes surgery in many ways. We did an audit of my clinical practice recently, and what we found was we have a higher prevalence of diabetes than national average for academic reasons, for geographic reasons, because our population has a high prevalence of diabetes. Once you compare patients with type 2 diabetes versus patients without type 2 diabetes, they typically have more severity of disease, generally speaking, more comorbidities. ASA score is more important. But when you look at their demographics, not only there's a difference in gender and balance, but there's also, of course, more risk from disease at baseline. People with diabetes, people use 3 times, 6 times more medications than people without diabetes, and they have twice as much prevalence of cardiovascular disease at baseline. So we are operating on patients who are substantially more sick, if you wish, than patients without diabetes. So in fact, this is emboldening us to operate on more and more complex patients as we go. You can see patients who have all sort of conditions here. This is to say one message, that when we talk about bariatric surgery, we think about the quintessentially elective procedure for the quintessentially healthy, borderline sick patients. In reality, 38% of my patients, according to CCI score, have a prognosis that is so bad that looks like what the prognosis of many cancers, actually some of the worst kind of cancers. These patients get the same priority as anybody else to get surgery, and they're not prioritized indeed for faster surgery. So what I think is happening now, and I hope you will agree, is that we are finally starting to see what metabolic surgery really means. It doesn't mean just operating on diabetes. It means to operate on patients that are no longer just on a scale of risk, but are more and more already patients with ongoing illness. And here is where you're going to see a difference in the fact that surgery is no longer a prophylactic intervention, but it's a therapeutic intervention. And perhaps this kind of change in mindset will make people accept surgery and embrace it more than historically has been the case. Thank you very much.
Thank you very much. The next speaker, last but not least, is Pauliina Salminen from Turku University, Finland. And you saw what Francesco showed. People think that metabolic surgery with the traditional and well-known operations is risky. So she'll speak to us about the innovative techniques. Are they friend or foe in the current practice of the new landscape of treatment of obesity? Please, Pauliina.
Thank you so much for the invitation. Good morning. And I will try to speed this up so we'll make it to the presidential session. So this was my title, and I really liked it. My disclosures are somewhat relevant to the topic because I'm an enthusiastic trialist and firm believer of evidence-based medicine. So as innovative procedures go, I think this is the context that we need to think about it, and maybe some of the journal work too would be for this talk. So it will be a very short talk if I show the evidence of the innovative procedures currently. So that's actually probably what I should do if we're running a bit late, because that's a quick talk. There really is not that much evidence. So this is something that we need to think about. And I'm just going to run through this to show you in this new era. I think we really need to have a different mindset. We can't be thinking about things the same way we did 20 years ago. So this is really a new era. This was a very good plenary session, and I like that slide. That's why I took the picture. I think we really, from a surgical perspective, we need to step up our game in doing our research within metabolic bariatric surgery. I think this, of course, aiming for higher quality applies to every single field in medicine, but I think this is something we really need to look into. And saying this, I'm not saying I'm not for pro-innovation. I think that's clear, but we just don't need to reinvent the wheel every time. And I think, like, when you look at different new innovative procedures, I do think that they should be done within the context of IRB supervision, because that's really what you need. You need to have more data over opinion. You need to have that supervision, because sometimes, and I'm just saying this with all love to my surgical colleagues, but sometimes it feels like, it's the Wild West. Everybody wants to have their own, in my hands is not really the idea of what you want to present for your results. So I don't have to show you, everybody knows evidence-based medicine. We need to do evidence-based surgery. Everybody knows the hierarchy of scientific evidence, and I think really questioning our own results and having the own results, that's of crucial importance. And when we look at the levels of evidence, and when we look at the current innovative metabolic bariatric surgery procedures, we're really at level 3. There are not really we don't have the data. So really, we need to do it. I'm not saying I'm against it. I'm really pro for it, but you need to do it within IRB supervision. So you actually need to know your results. And when you compare it, I think the crucial idea is also that we do have level 1 evidence of procedures that we already have with long-term available data from RCTs. And this also, I think, is within the new era of GLP-1s, is that the medical research is really high quality. So we need to match up that, because we're really living in an era that we have a lot more tools in the box. I'm just going to show you a quick example of SADI-S, which is something that's increasingly being done. This was an IFSO statement in 2018 and then 2020. And as you can see, the difference, during the 2 years, not really that much more papers coming out. So really the evidence, even though the procedure is something we do on a regular basis quite often currently, and they're increasing. It is really a very, very scarce evidence. And when you look at the quality of the studies, so there was out of the 42 in the updated version, only one study had low risk of bias. All the others were not that high quality. So this is something that we have to consider. So this is a very surgical, concise flowchart, how to choose your study type. But I think if you think about if it's possible to do randomization, just do a randomized controlled trial. I think that's kind of simple. And as we are in Australia near New Zealand, so I think this is adopted from IFSO, their trial network, and kind of gives you the idea. I'm not saying that it's easy to do an RCT, but of course that's possible. So all of that takes a whole lot of time, and conducting a randomized trial is kind of like Amazing Race with all the roadblocks and, you know, hurdles and brick walls and some more of those, but still we need to do, because if you want to have a new intervention and innovation, you need to do an RCT to compare it to the actual gold standard of that time. These are the courtesy of our current IFSO president-elect, soon to be IFSO president, Ricardo. I think this is a very good idea of when to do it. If the operation new in principle of surgical techniques, yes, you need a randomization. If not, and if you're not claiming superiority, but if you are, you need to do an RCT. If you're not, then you can think about any significant changes or new indications. If yes, you need to do an RCT. And if not, then perhaps small prospective registries if you're not really doing anything different outside your previous practice. I just wanted to show you a BGS paper that was out last year with 2 decades of surgical randomized controlled trials. So they were analyzing what happened within the 2 decades of these RCTs. So there were like in 1999, 2009, and 2019. So a bit over 1,100 surgical RCTs were identified. And not just to say I'm promoting Scandinavia, but this is, I think, very interesting. So top 10 by relative volume of surgical RCTs per 10 million inhabitants. So you see a lot of the Northern European countries there are actually really on top of the list throughout these 2 decades. And still we're not doing enough RCTs. So we really should step up this game. The good part is that during the 2 decades, the RCTs are improving in quality. So that's a good thing. But of course, we still have a long way to go. And even though my topic was innovative surgical procedures, is really, I think we also need to improve our higher quality research. And to end, I would also promote having, because of course it's not always possible to do an RCT. You need funding, you need a lot of time, you need a lot of energy, and maybe be a bit crazy to do it. But you can always do like prospective cohort studies. That's not such a big of an issue to do it. And I think this is a very good, with all of its limitations, I think this is a very good example of the Papadilla paper, the Genoa group of looking at their BPDDSs at long-term follow-up, because the long-term follow-up for the chronic disease of obesity is something that we really, really need. So they did have, it was a very low follow-up rate at 30 years, 19%, at 20 years, 61%, and still with even the very low follow-up rate at 30 years, they were able to, show the nutritional complications. And this is really the only paper that provides 30-year results. So this is something that we also need to focus on the innovative procedures. And I really enjoyed writing the paper with, actually all the authors are within the room. So, but it is a balance between, getting good outcomes and balancing it with potential nutritional issues and other adverse outcomes. And this is something we don't have for the innovative procedures. I would like to conclude with the idea that I think clinical surgical science we're moving towards doing together. And I think that what we really need to do now within this new era is to really have a collaboration with the obesity physicians, endocrinologists, and do research that is within the context of the current OMMs. And this was the IFSO consensus from this year held in Vienna, and the paper hopefully is coming out soon. So we really need to have collaboration, and it would be much easier to do the multi-center RCTs as the northern countries do. So in conclusion, for the innovative procedures, I think we need prospective observational cohort studies and big data. They need to be entered into a registry so we actually follow them up. If we're not doing RCTs would of course be preferable, but at minimum a prospective cohort with long-term follow-up. And to go back to our editorial, I think really this reminds that all of these innovative procedures should be done under IRB supervision as stated by the IFSO position statement on these innovative metabolic bariatric surgery procedures. So we need to have that until long-term quality data on safety and outcomes is available. So thank you very much for your attention, and I think this is the key issue. See, I saved you.